Hi, this is Brittany Moore. Today is November 3rd, 2025, and I'll be recording my cardiovascular assessment. Here is my ear scan, and then here's my room scan with the floor, and then the ceiling. And I just need to get my hand mirror really quickly. There is my computer, and I've got my ruler and then a blank card to measure the JVP. So I'm going to go ahead and get started. First, I'm going to clean my hands with hand sanitizer. Hello, how are you?
Good, how are you?
I'm well. My name is Brittany Moore. I am a family nurse practitioner student with the United States University, and I will be completing a cardiovascular assessment on you today. Before we get started, I just need to get consent to record a video of this assessment and then upload it to YouTube so my professors can view it and grade it. Can I have your consent?
Yes.
Great. All right. Can you start by telling me your first and last name? You can give me your initials and your birthday.
DR, September 14th, 2006.
Great. And how old are you?
19.
Wonderful. So the patient's old enough, he's an adult, he can consent for himself. Okay, so the first thing that I would start with on any cardiovascular exam is a bilateral blood pressure. So on both arms with an appropriate size cuff, measuring the blood pressure in both arms allows me to assess if there's any changes, which would be an unexpected finding. And then I would also assess the blood pressure from a supine position and then in an upright position, and that would allow me to assess for any changes related to position change or any orthostatic concerns. So the first thing that I'm going to do is I'm going to measure the jugular venous pressure, and to do that I'm going to assess this from the right side of the patient. I am on his right side, and I do have him laying supine in a bed that has the head elevated to between 30 and 45 degrees. And then I'm going to have you go ahead and just look to the left. And I am going to look here for the highest point of oscillation of the right internal jugular vein. And once I've identified that, I am going to place my ruler in the centimeters in the sternal notch, and then I'm going to use the card to measure this. So I've got my ruler there, and the highest point of oscillation is right there. And coming over to a 90-degree angle, that puts that at 2 centimeters, which is a normal finding. Anything 3 centimeters and below is considered a normal finding. So the next thing I'm going to do is I'm going to assess the carotid arteries. I will never palpate the carotids at the same time. That would reduce the blood flow to the brain, which can cause injury to our patient, which we do not want. So I'm just going to palpate the lower third of the neck, and I'll start on the left side. And I'm feeling for the pulse, which is +2. It's brisk. It's a regular rate and rhythm, and there's no thrills. And then moving over to the right carotid in the lower third of the neck, and again I am feeling a palpable pulse. It's a +2 in amplitude, it's brisk, regular rate and rhythm, and there's no thrills, and that is a normal finding. Next I'm going to auscultate the carotid. So I'll start again on the left, and I'm listening with both the bell and the diaphragm, and I would have my patient hold their breath for approximately 10 seconds on each side while I do this, but I'm just going to verbalize that for this assessment. So I'm listening with the diaphragm and the bell, and I do not hear any bruits. And then on the right side, with the diaphragm and the bell, and I do not hear any bruits, which is a normal finding. Now I'm going to assess the chest for any abnormalities. As I'm assessing the chest, I see that the sternum is midline, and I do not see any pectus excavatum or pectus carinatum, and there's no precordial pulsations, and I do not see any pulsations at the apical impulse either. And that is a normal finding. So now I'm going to assess or palpate for the PMI, which is the point of maximal intensity or the point of maximal impulse. And that is at the midclavicular line at the left side of the sternum at the 5th intercostal space. And so to assess for this or palpate for this, I'm going to have my patient turn over onto his left side and I'll palpate there. So go ahead and turn onto your left side. And it's a little hard to see this with the camera, but just so you know what I'm doing, I am palpating at the midclavicular line at, sorry, my hands are a little bit cold. And then go ahead and hold your breath. Great. And so you can turn back over. I felt a brisk, easily palpable pulse, no heaves, no thrills, and no lifts. I would say that was +2 in brisk in that apical pulse, apical impulse at the apex area of the heart. So the next thing I'm going to do is I'm going to start by palpating in the 5 sections of the heart. And so I'm going to start here at the aortic region, which is on the right sternal border at the 2nd intercostal space, which is right there. And I'm feeling for any heaves, lifts, or thrills, and I'm not feeling any. Then I'm going to move over to the pulmonic region, which is the left sternal border and the 2nd intercostal space. Again, feeling for lifts, heaves, and thrills, and I'm not feeling any. And then moving down to the Erb's point, which is the left sternal border and the 3rd intercostal space. Again, not feeling any lifts, heaves, or thrills. And then the 4th intercostal space on the left sternal border. This is the tricuspid region, and I'm not feeling any lifts, heaves, or thrills, and that's a normal finding. And then moving to the mitral valve region, which is at the midclavicular line at the 5th intercostal space on the left side of the sternum. And again, here I just palpated in the same region for the PMI, and I'm not feeling any heaves, lifts, or thrills, and that's a normal finding. Next, I'm going to palpate the abdominal aorta. So I'm coming into this epigastric region, and I'm going to palpate this. And I'm not feeling any pulsatile mass. The aorta is typically about 3 centimeters, which I am able to measure and feel. And it's in this section of the epigastric region that is slightly to the left of midline, and that is a normal finding. So the next thing I'm going to do is I'm going to auscultate, again, in those same 5 areas that I just palpated, and I'm going to start at the aortic. And then I'm moving to the pulmonic. And then take a deep breath in. And out. And then the Erb's point. The tricuspid. And the mitral valve. And that was with the diaphragm. And now with the bell. And that's the aortic. And the pulmonic. The tricuspid. Excuse me. The pulmonic, the Erb's point. The tricuspid, and the mitral valve. Now, as I was auscultating over those 5 regions of the heart, I've already detailed where they're located along the right or the left sternal border and which intercostal space. I detailed that while I was palpating. But as I was listening, I'm listening for any S1, S2, which is the normal heart sounds. I'm listening for any murmurs, bruits, gallops, friction rubs, or any abnormal heart sounds, any others. And I did not appreciate any abnormal heart sounds. The only thing that I heard is S1 and S2 in those 5 regions, with the exception of over the pulmonic region. I did hear a physiologic split of the S2. And the physiologic split of S2 is related to during inspiration, the intrathoracic cavity expands, and that reduces the intrathoracic pressure, which then causes an increase. There's more blood flow at that point in the right side of the heart, and then due to lower vascular resistance in the pulmonary arteries, it causes a delay in the closure of the pulmonic semilunar valve, and it closes a moment after the aortic semilunar valve, and that is the reason for that physiologic split. So that's a normal finding. So the next thing I'm going to do is I'm going to listen to the aorta, the abdominal aorta, with both the diaphragm and the bell. That's the diaphragm and the bell, and I'm not hearing any bruit. I'm also going to listen to the femoral arteries, and for the privacy of this video, I'm just going to listen over the closing. In clinic, I would listen on the skin, and I would have the patient draped. So with the diaphragm and the bell, and no bruit, and then no bruit, and that's a normal finding. And so now I'm going to do an assessment of the vascularity. So first I'm looking at the extremities, and I'm looking at the skin of the extremities. The skin is pink, it's normal for ethnicity, it is warm and dry. As I continue looking, I'm not seeing any shunts, I'm not seeing any varicose veins, I'm not seeing any edema. The color of the skin, I'm not seeing any shiny skin, there's no rubor, there's no ruddiness, and I'm not seeing any pallor, and that is all normal findings. I'm also going to assess the pulses. So I'm going to start here with the radial pulses, and I'm going to palpate all of the pulses bilaterally at the same time. So as I'm palpating the radial pulses, this is a +2. It's brisk and a regular rate and rhythm, and there's no thrills. And then the brachial pulses. These are +2, regular rate and rhythm, brisk and no thrills. Next, I'm going to palpate the femoral arteries. These are +2, regular rate and rhythm, brisk, no thrills. The popliteal, so these are behind your knees. And this fossa, right there. And this is also +2, regular rate and rhythm, brisk, and there's no thrills. Moving down to the posterior tibial, I'm going to have you put your feet up like this just so I can show this on camera. And this is behind the medial malleolus, and between the medial malleolus and the Achilles tendon is where you'll find this. And this is +2, regular rate and rhythm, brisk and no thrills. And then also the dorsalis pedis is +2, regular rate and rhythm, brisk with no thrills. So all of the pulses are within normal limits. Next, I am going to assess the capillary refill of all of the fingers and toes. So as I'm first looking at the fingers and the toes, I am seeing no clubbing, there's no cyanosis. I'm not seeing any splinter hemorrhages or any tar stains, and tar stains would be an indication of lifestyle choices like smoking. Splinter hemorrhages would be concern for endocarditis, and then clubbing and cyanosis would be a concern with hypoxia, and then COPD with the clubbing or other pulmonary diseases. So as I'm checking the capillary refill, the cap refill in the fingers is brisk with light pressure. It returns in less than 3 seconds, and then again in the toes, it's brisk and it returns in less than 3 seconds. And so that is considered a normal finding. Let me just think and make sure I did everything. Okay, I think that's it. Thank you.